Good morning. I am Dr. Angelito Benjamin C. Belen, the Chair of the Philippine College of Physicians Committee on Climate Change. Welcome. This is the first of a series of Physicians Caring for the Planet webinars. Allow me to introduce the President of the Philippine College of Physicians 2020-2021, Dr. Mario M. Panaligan. Allow me to introduce the
Good
President
morning,
of the
colleagues
Philippine
and
College of
friends.
Physicians
BioMedical
2020-2021,
wastes in the COVID
Dr. Mario
pandemic.
M. Panaligan.
This is indeed a
Allow me to
very
introduce
important webcast conference, especially at this time when we need to be
2020-2021
biomedical waste constantly on the guard in terms of our safety against COVID-19 disease. Truly busy and hectic with all the means and interventions targeting the current menace. All of us must keep on track with the various problems posed by climate change. Definitely, along with the vision of the College of sustaining the highest standards and ethical ideas in the practice of medicine, with one of its mission to be responsive to environmental changes, our stand shall continue, and that is to remain vigilant, acting immediately with purposive advocacy on pursuing relevant actions to control the environmental crisis we are having, especially now with the COVID-19 pandemic. The two priority projects of the committee, which are education, the modified curriculum to include climate change, and the primer that will soon be released, plus the biodiversity protection through the November 8th Day of Rising, shall go on. Add to this is Recon 2020, the carbon footprint of PCP. People empowerment with the engagement of various stakeholders shall proceed with the different programs and activities by our Climate Change Committee, headed by our chair, Dr. Lito Belen, and our co-chair, Dr. Paula Santamaria. Let us move and endure as we unite hands in our effort to combat the deleterious consequences of climate change. Stay safe, and thank you very much.
Our speaker for this morning is an internist pulmonologist, having finished a residency training in internal medicine at the University of the East Ramon Magsaysay Memorial Medical Center and her fellowship in pulmonary medicine at the Lung Center of the Philippines. She is a fellow of the Philippine College of Physicians, a fellow of the Philippine College of Chest Physicians, president of INSPIRE Respiratory Team in Region 8, 2019. She is the chair of the Alliance in COPD Education and Support, or ACES, in Region 8 since 2006. She is also the chair of the Department of Medicine of the Remedios Trinidad Romualdez Hospital from 1998 to the present. She is the chair of the TB Diagnostic Committee of the Remedios Trinidad Romualdez Hospital Public-Private Mixed DOTS since 2005, and the research coordinator of the Department of Internal Medicine, Divine World Hospital. She is a recipient of various citations and awards, among which the 1997 Outstanding Young Researcher Award of the Philippine College of Chest Physicians and the Most Outstanding Member of the Philippine College of the Physicians in August 2015. She is the author of various researches and publications and the chair of numerous scientific committees. Ladies and gentlemen, colleagues, allow me to introduce my co-chair in the Philippine College of Physicians Committee on Climate Change, Dr. Paula Teresa Pilamor Santamaria.
Thank you, Dr. Belen, for the kind introduction. Good morning, Dr. Panaligan, to the officers and members of the Philippine College of Physicians, and to all our viewers. Kumusta na po kayo lahat? This morning's presentation will highlight biomedical waste in the COVID-19 pandemic, its impact on people and planetary health. These are the objectives of my talk. Let's take a look on what are biomedical waste, what is the significance of biomedical waste. Let's tackle the challenges in handling biomedical waste in the COVID-19 pandemic and the small steps yet global impact for green Earth. The health industry is one of the world's largest and flourishing industries. It utilizes more than 10% of gross domestic product of affluent nations. In its mission to deliver preventive, therapeutic, rehabilitative, and palliative care, the health industry creates waste that may itself be hazardous to health and impact on climate change. Climate change is the greatest global threat in the 21st century, and climate change impacts like heat waves, floodings, air pollution, changes in vector ecology, food and water shortages, environmental degradation, all these will increase the demand for healthcare services. According to independent analysis of NASA and the National Oceanic and Atmospheric Administration, the Earth's global temperature in 2019 were the second warmest since recording started in 1880. So using climate models, the scientists concluded that this increase was driven by carbon and other greenhouse gas emissions brought about by human activities. This alerted 11,000 scientists from 153 countries to come together in December 2019. They declared a climate emergency. Year 2020, climate change burned the Amazonian and Australian rainforests. Recent wildfires razed the US West Coast, and climate change is melting the ice caps in Antarctica and brought typhoons, big floods, and now climate change contributed to the COVID-19 pandemic. As I speak, the incidence of COVID-19 is more than 31 million, with mortality escalating to more than 965,000. In the Southeast Asian region, the Philippines ranked first in incidence, and this COVID-19 brought us to a new normal where society have to wear masks and face shields. Nowadays, everything is delightfully packaged as disposables. So we have disposable kits, disposable masks, disposable face shields, disposable PPEs, disposable gloves, everything to go. If we keep on with this disposition to dispose, ultimately, this will create a biomedical waste pandemic. What are biomedical wastes? Biomedical wastes are the infectious waste or medical waste generated during the diagnosis, testing, treatment, research, or production of biological products for humans or animals. There are non-infectious wastes, which would be 80%, pathological and infectious waste 15%, chemical and pharmaceutical waste would be 3%, and sharps, radioactive, cytotoxic, and heavy metals 1% each. Biomedical wastes are generated by hospitals and health facilities, by blood banks and collection facilities, nursing homes for the elderly, mortuary and autopsy centers, animal research and testing laboratories, and laboratories and research centers. Originally, biomedical waste would be contained within these facilities, but as we transition now to home care and palliative care, biomedical waste find their way into the communities. With the advent of COVID, where everybody needs to wear a mask and a face shield, biomedical waste is everywhere. It has even found its way into the ocean bed. Biomedical wastes are collected and segregated at source and placed into their designated bins. There are 5 ways of treating biomedical waste: by incineration and non-incineration systems. Incineration is typically for pathological waste and pharmaceutical products, but never for plastics. The greener options would be thermal or autoclaving, irradiative or microwave, chemical and biological enzymes. Why do we need biomedical waste management? Firstly, it is harmful to the public. In 2010, there were 16 billion injections administered worldwide, but not all the syringes and needles were accounted for and disposed properly, creating the risk for injury and infection and the potential for reuse. Unsafe injections accounted for 33,800 HIV infections, for 1.7 million hepatitis B infections, and 315,000 hepatitis C infections. One needle stick injury will increase the likelihood for HBV risk by 30%, hepatitis C by 1.8%, and HIV by 0.3%. Incineration is a predominant medical waste management in the developing world. This is associated with risk for thermal burns, chemical burns, and radiation burns. Our present understanding now is that incineration does not make waste disappear. It transforms it to toxic energy. So we have particulate matters, carbon monoxides, the dioxins and furans, acid gases including hydrochloride, and toxic metals like lead, cadmium, and mercury. Add to that, the incineration ash is equally toxic. Incinerator pollutants are hazardous to health. Particulate matters, which are respirable, could aggravate asthma exacerbation. It could cause a decline in lung function, premature death for people with heart or lung diseases. Carbon monoxide competes with oxygen and causes shortness of breath, dizziness, and heart disease. Arsenic is irritating to the lung and throat and has skin effects as well. Hydrogen chloride could exacerbate chronic bronchial inflammation. Chromium is associated with lung cancer. Mercury has CNS effects, and polyaromatic hydrocarbon increases the risk for skin, lung, bladder, and GIT cancers. Lead causes delayed learning in children. At the disposal sites, hazards from scavenging is mainly because of loss of social distancing, and the scavengers and sanitation workers are not adequately protected. Biomedical waste is harmful to the environment, and this is expressed by the carbon footprint, which is the total output of greenhouse gas emission by an individual, organization, or an event. Carbon is used as a surrogate for all greenhouse gases for the reason that this is a dominant gas. This diagram illustrates the scope of the carbon footprint. There are three scopes. Scope 1 would be the direct scope greenhouse gas emission from the use of facilities and company-owned vehicles. Scope 2 is the indirect greenhouse gas emission of the company secondary to the purchase of electricity for heating, steaming, and cooling the facilities. Scope 3 would be the optional greenhouse gas emission, which is indirect, coming from total purchases of goods and services, businesses, travel, and waste disposal. We see here the carbon footprint of the healthcare sector, and we could see that Scope 1, there is 17% of greenhouse gas emitted by the company. The healthcare sector would have an indirect greenhouse gas emission of 12%, owing to the purchase of electricity, steam, or chilled water. But a big chunk of the carbon footprint comes from the optional indirect greenhouse gases, which is 71%. This comes from the waste generated from flights, travel, and purchased goods or services. The top three emitters of greenhouse gases are the United States of America, China, and European Union. If the health sector were a country, it would have been the 5th largest emitter on the planet. The healthcare's carbon footprint is 4.4% of global net emissions. This is 2 gigatons of carbon dioxide, which is equal to the annual greenhouse gas emissions from 514 coal-fired power plants. There are laws governing biomedical waste management. In the Philippines, we have the Republic Act 9003, or the Ecological Waste Management Act of 2000. The Act provides for ecological solid waste management program and requires mandatory segregation of solid waste at source. This should be properly labeled as compostable, recyclable, non-recyclable, and special waste. All LGUs are mandated to reuse, recycle, and compost 25% of the solid waste. The second act is the Republic Act of 6969, which is the Toxic Substances and Hazardous and Nuclear Waste Control Act of 2000, which regulates the use and disposal of chemical substances and mixtures that present unreasonable risk and or injury to the health or the environment. These are the challenges in handling biomedical waste in the COVID-19 pandemic. Let's take a look at the Wuhan, China scenario. At the outbreak, they needed to build new hospitals. With new hospitals, new medical waste plants were also constructed. The daily production of masks soared to $116 million in February, which is 12 times higher than that of the previous month. Hospitals generated 6 times more medical waste at the peak of the outbreak, amounting to 240 metric tons of medical waste daily, compared to the usual 40 tons pre-pandemic. They had to deploy 46 mobile waste treatment facilities. In the USA, the country rated most prepared for a pandemic, which has nearly a quarter of all COVID-19 cases and more than 20% of deaths, Frost and Sullivan predicts that the US could generate an entire year's worth of medical waste in just 2 months, just because of COVID. In Mumbai, India, there was a 104% increase in biomedical waste for 3 months. The city's waste incineration unit has run out of storage space at their 1-acre plant in Dayuna, and biomedical waste weighing 2,000 kilograms were incinerated daily, worsening air pollution. Bangladesh threw 14,500 tons of biomedical waste last April 2020. In the Philippines, DENR reported a 19,187 metric tons of infectious waste starting from April, May, June, and July. Last year, we produced 88,878 metric tons of infectious waste, meaning nowadays it will only take 4 months for us to come up with the same number. Only 29% has been treated and disposed of, although the waste has already been hauled from the hospitals. Worse, the Eastern Visayas region, Zamboanga Peninsula, and Sorsogon do not have waste treatment facilities. Republic Act 9003 mandates the segregation of solid waste at source. But for the garbage collectors, all they have to do is fill up their trucks, haul the waste to the sanitary landfill, segregated or not. Residents of Abuyog Leyte seeks accountability for their used rapid test kits that were dumped in Sitio Balinsasayao last August 21, 2020. And we have heard of this news report of a show cause being tendered to a laboratory for violation of Republic Act 9003. This followed when a trail of used test kits were found littered in the Sampaloc, Manila Road. This is a usual sight nowadays, and Eco Waste Coalition shouts, "Do not litter your face mask." At the dumping site, we could see that social distancing is not observed, and worse, the sanitation workers and even the scavengers are not adequately protected. So surely the challenges in handling biomedical waste in the COVID-19 pandemic is secondary to the surge in biomedical waste and the infrastructure mismatch. In the Philippines, there was failure to deliver Republic Act 9003. There was poor monitoring and verification of biomedical waste. The chances of mishandling biomedical waste is very high, and also there is inadequate waste storage. Treatment of biomedical waste is improper, and worse, there is none at all. The compromised safety of waste handlers and sanitation workers, and no social distancing was observed at the waste collection sites. Something good can come out of this global crisis that can be addressed by nations acting as one, not as separate and sometimes competing groups of people. And I think it's all in the attitude. The law is in place. What we need is a resolute personal and political will to implement the law to the letter. Recently, the House of Representatives passed a Better Normal for the Workplace, Communities, and Public Spaces bill. And we hope this would be the muscle that will monitor the implementation of Republic Act 9003. This is a beautiful sight to behold at the Manila Bay. Crushed dolomites are seen in the bayfront. But how long will this keep? Even Roy C. Matu laments that we have to address behavioral and cultural realities that have made garbage throwing in the country, especially in Metro Manila, so prevalent. We have to support House Bill 6864, which proposes to develop single-use packaging alternatives. There are organizations working for planet health. Foremost would be the World Health Organization. They developed the first global and comprehensive document on the self-management of waste from healthcare activities. This would be a very good resource for countries and hospital administrators who want to develop their own biomedical waste program. Central to this is that the coronavirus waste should be treated like any normal infectious waste, and we should say no to incineration, but favor green options like autoclave and low heat thermal processes, chemical processes, irradiative processes, and also biological processes. Disinfectants against SARS-CoV-2 could also be used, especially chlorine. For blood spills, we could use 1% and 2%. For general surface disinfection, we could use half strength to 0.1%. General cleaning would require 0.05% for 10 minutes. For contaminated linens, we have to soak the clothes for 30 minutes in 0.05% solution. The UN Environmental Program is the leading global voice on the environment and enables nations and people to improve their quality of life without compromising that of future generations. They also developed the UN Basel Convention's technical guidelines on the environmentally sound management of biomedical waste. Again, this is a very good resource for biomedical waste management programs. This talk is all about reducing our volume of biomedical waste and reducing our carbon footprint. Not everybody needs to don a PPE. This is provided for in the interim guidance report of the World Health Organization's document on the rational use of PPE for COVID-19 and considerations during severe shortages. PPE should be worn in special units handling directly COVID-19 patients. These are the virology labs, consultation rooms, COVID-19 dedicated units in the ER, ICU, wards, OR, and delivery room. Ambulance should also have a PPE and points of entry, airports, ports, and bus terminals. Who should use the PPE? Healthcare professionals, cleaners, ambulance drivers, and staff at points of entry. We could see here that the document gives us the recommendations on when to use the PPE at different settings. So here at the outpatient facilities, for example, we could see that at the screening triage, we don't need a PPE, but we should have a glass plastic partition between the healthcare worker and the patient, and our patients and healthcare workers should have a mask and adequate eye protection. I would encourage you to read through this document. This is a very important resource for all of us. The Center for Disease Control came up with a standard of use of N95 filtering face-based respirator. N95s are meant to be disposed after each use. However, CDC came up with a contingency and crisis strategy to facilitate conservation of health supplies. Two procedures are supported: decontamination and the limited reuse strategy to reduce the risk of self-contamination. A limited reuse strategy to reduce the risk of self-contamination entails that each healthcare staff member is given 5 N95 FFRs. They wear one N95 FFR each day and then store it in a breathable bag at the end of each shift. They reuse the mask again after 5 days. The rationale here is that the pathogens will die off during storage. CDC, however, recommends no more than 5 donnings per device. However, if there is already evidence of soil, the N95 has to be discarded at once. Potential methods to decontaminate FFRs are UV germicidal irradiation, vaporous hydrogen peroxide, and moist heat. CDC does not support the use of soap and water in decontaminating our FFRs and face masks. So the next time you reach out for a PPE, please, let's have none of this. Pasyente naman ang babayad nito. Rather, let's have a conscience. And always remember, will using this PPE contribute to my safety and my patient? And more importantly, this my share to reduce my carbon footprint? We need earth, doctors, And the Healthcare Without Harm is an international NGO that works to transform healthcare worldwide so that it reduces its environmental footprint. It becomes a community anchor for sustainability and a leader in the global movement for environmental health and justice. They came up with 6 actions for climate-smart healthcare. Action 1 requires the reduction of healthcare's climate footprint now by supporting a societal transition to clean energy, and that by 2050, we would have reduced our emissions. This is made possible by developmental assistance for climate-smart healthcare and establishing and implementing government actions for climate-smart healthcare. We should deepen research on healthcare and climate change. Our Philippine College of Physicians is a world-class organization of physicians that sets the highest standards and ethical ideals in the practice of internal medicine. One of its missions is to be responsive to the changing environment, and this was put to a test during the Haiyan crisis. PCP responded by coming up with a Climate Change Committee. Leading this initiative is the mantra, to teach, to plant, to protect. Since then, we have reached out to 34,800 audience for climate change education. We have launched a climate change and health primer. This will be the textbook that will be used for the tertiary and medical schools curriculum on climate change. We have planted 31,000 trees, and the PCCP supports 10 sites for 10 years biodiversity protection projects nationwide. This is now on its 3rd year. In the biomedical crisis, will PCP lead the way again? I believe that we are credible leaders in health and advocacy, and we have the capacity to influence behavioral changes and policies. All of us must have a sense of stewardship for creation, and I would like to recommend these small steps, yet have global impact. First is we should stop eating or eat less of red meat. Remember, cows have a very high carbon footprint. We should unplug our devices. Remember that appliances that are plugged still consume electricity even though it is not put on. We should drive less and don't buy fast fashion. We should plant a garden, eat local, not imported goods, and lie dry our clothes. We should make each day an opportunity to reduce, reuse, and recycle our solid waste. In conclusion, biomedical waste is dangerous to both human and planetary health. The COVID-19 pandemic brought a surge in patients. It generated massive amounts of biomedical waste. We need to implement the law on ecological waste and shift from incineration to the use of autoclave and other green options to treat biomedical waste. The COVID pandemic have proven that we need to strengthen our health system, and the PCP is in a position to promote resilience, mitigation, and leadership as solutions towards environmental justice and equity. It is only when we have put the best interest of our planet alongside with public health can we say that we are true to our Hippocratic oath to first do no harm. That would be the last slide in my presentation. I would like to acknowledge my cheering squad, the Climate Change Committee of the Philippine College of Physicians, especially my boss, Dr. Lito Belen, and the COVID Resource Center of Healthcare Without Harm. Please let me leave you with this, BMW. Not Bavarian Motor Works, but please be mindful of waste. Thank you for joining us in this morning's webinar. Have a good day ahead.
Thank you. Thank you, Dr. Paula Santamaria. That was a very excellent presentation on biomedical waste during this pandemic. I'm sure you have presented an eye-opener for the rest of the college regarding this particular problem in this pandemic. Now we are opening the floor now for questions and answers. Should you have any questions, you may type them, send them over to our chat box, and Dr. Paula will address it and answer it to the best of her abilities.
Hi, sir. Firstly, I would like to correct the curriculum that from my curriculum vitae, I am not the chairman of the Department of Medicine of RTR now. I would like to give credit to my very good friend, Dr. Salvacion Sible Tivera, who is now the chair of the RTR hospital. When we started off, I got a text, and the question here was, do we have a waste problem because the government is not doing its job? And I would like to answer that now. And the analogy would be like this problem in BMW has something to do like cooking a dish. We should have a good recipe, we should have the proper ingredients, and we should have a very good cook. So with a BMW, the laws are in place. We have the Republic Act 9003. The government is needed to provide the framework and also the logistics to carry out this program. But the most important player here are the cooks, which are us. And I feel that we are unwilling cooks in this dish. I feel that if we could all come together and do our share in segregating, which is the first mandate in the Republic Act 9003, then I think the sanitation workers whose job is to hold this trash and then dump it in the sites, then we don't give a chance for scavengers to do the sorting for us. So I think this is something that is not a point finger to the government always. We should start pointing it to ourselves. What are we doing to take care of this problem?
So, Paula, there's a question here. How long can we use our face shield?
Yes, sir. The CDC recommended that we could use it for only 5 times, but after 5 days, meaning to say that if I have a face shield now, I have to put it in a rebreathable bag for 5 days to allow the pathogens to die during the storage. And then I get to use again after 5 days. So there is conservation of supplies now because what will happen, every healthcare worker will only use 5 to 6 face shields per month compared to 1 face shield per day, which would be equal to 30 face shields. So definitely that's a big drop in our carbon footprint because we are using less supplies.
Okay. There's another question, which is, what are the low-heat biomedical waste treatment facilities?
Okay, biomedical waste treatment, as I mentioned earlier, we have the incineration, but we say no to that. And we would like to go for the non-incineration, or the greener options would be very predominant, would be the autoclaving and the thermal processes. So we could also deactivate or decontaminate our biomedical waste by using your chlorine or for your chemical means.
So here is another question. How about those N95 masks that are washable? Can it be reused?
Washable. As I mentioned earlier, the CDC would only say that they could do ultraviolet, if you remember, moist heat, but nothing about soap and water. So I don't think it's possible to do that because otherwise they would have given that in our recommendation. It's a recommendation that we can just wash our filtering face piece or your N95s for use. So let's use the limited reuse strategy wherein you use the face mask after 5 days again from the last time you used it.
So this is a good question. Very relevant. To what agency can we report our LGU if our municipality is not doing its job of waste management?
Okay, so that would be the DENR. If you remember, the one who tendered also the show cause on the clinical laboratory who violated Republic Act 9003, it has to be forwarded to the DNR.
There's another question, although you have probably partially answered this. Are the LGUs to be held responsible for the lack of waste management facilities in the Eastern Visayas, Zamboanga Peninsula, etc.? And what has been done to address this?
Yes, like I said, we have a good recipe. We should have a good infrastructure, the ingredients, and we should have willing players in this game. So the law is already in place. What the government should do or the LGUs should do was to improve, to really give the infrastructure and provide the logistics. So in Eastern Visayas, like I said, we don't have the waste treatment facilities. So like any good cook, you have to come up with a resource on how you could go about delivering a good biomedical waste management program without this waste treatment facility. So it's really a challenge to these areas, especially on my region where we don't have a waste treatment facility.
Okay. This is another relevant question from one of our participants. Does putting infectious waste in yellow plastic bags or bins give them to garbage collectors enough? And hospitals and facilities should be required to have their infectious waste be rightly handled, even if they might have to hire contractors that ask for payments per kilogram. What can you say about it?
Like I said, in Republic Act 9003 starts at our home and in our hospitals. So our job is first to segregate because the sanitation workers, the one who bring out the garbages from our facility, their role is to bring it out, not to sort it out for us. So when we don't do the sorting in our hospitals, somebody gets to do that. Those are the scavengers.
Again, another interesting question. Just a query. Do you have data regarding the footprints of biomedical waste in the level of hospitals? If so, what specific measurements are we using in quantifying the footprints of biomedical wastes?
Well, that is the greenhouse gas emission. So the first scope would be the direct scope, which is the use of the facility and also the ambulance or company-owned vehicles. So we could take note of our carbon footprint by number one, just tracking the electricity that we are using and how much gas are we spending for every month. So that way we could take a track, we could take a look on just how much greenhouse gas emission we're putting out. The second would be the scope 2, which is the purchase of electricity to power the facility. Okay, so you take note of how much is your electric bill. If your electric bill is very high, then that means to say that you are emitting a lot of gases or your greenhouse gases. And the biggest one would be the indirect optional. They said optional because you can do away with that indirect greenhouse gas emission. So those are the recreational types that we have, and maybe we could cut down on the supplies that we need and really source out the buying or the purchasing of supplies, which is not so far away because these supplies, when it comes to your place, it has a very high carbon footprint also when you fly those supplies to your place. So for example, the use of gowns. Instead of having to buy those gowns, which are bought from one place and it has to be flown to your vicinity, why don't we ask our seamstresses or dressmakers in the hospitals or within the vicinity to do it? Not only do we give them employment for their daily need, we have also decreased our carbon footprint. You have a busy Q&A there, Doctor.
So, Paula, Maria, that's probably the reason why you mentioned to buy local instead of imported. Am I right? Yeah, to minimize the transport facilities that would utilize and increase carbon footprint.
Yes, sir. Like I said, that would be an indirect optional, meaning we can do away with that one.
Okay, so some of the questions that were already posted have already been answered. Okay, so if in case that you have any more questions, you can always post it to the PCP website, to the Climate Change Committee, so we can answer it even after this particular webinar. So,
Thank you so much for your kind attention. I hope this goes a long way to also rallying everybody to do their share in preventing or reducing this biomedical waste pandemic.
okay, thank you, Paula, Dr. Santa Maria. And for parting words, now I'd like to thank our audience, those who have participated and contributed to this webinar. I'd like to thank the PCP, especially the Secretariat. And this will not be the last. This is just a jumping point to the next series of webinars. So again, thank you very much and hopeful that we will see each other again. In case you missed this webinar, you can still watch this at YouTube, or you might want to look for the next webinar date on Saturday together with the Medicine Week celebration of the Philippine Medical Association. Okay. So with that, I would like to end this webinar. And again, let me remind you, BMW is be mindful of waste. Thank you very much and have a good day. Keep safe, everyone.
Thank you.